Hello, my name's Ian McCall, and this is a short talk on the systemic antifungals. They're quite a fascinating group of drugs. Fascinating from the point of view of how they get to the skin, how they're metabolized, and how long they actually stay there. Now, the main groups that you're going to look at, or the main drugs you're going to look at, are terbinafine, itraconazole, and fluconazole and ketoconazole. Terbinafine and itraconazole are both metabolized quickly by the liver, so you only get about 50% bioavailability, whereas fluconazole, you get about 90% bioavailability. Terbinafine is it's a drug that gets into the skin through what's called passive dermoepidermal diffusion, and also through sebum. And it gets into the basal keratinocytes, and as they go up to the surface, so the terbinafine level builds up as well. But it's interesting that high concentrations of terbinafine are reached in the stratum corneum within hours of starting therapy. One of the books I was looking at commented that 250 milligrams daily for 12 days will give drug concentrations above the minimum inhibitory concentration for dermatophytes for about 2 to 3 weeks after the oral therapy is discontinued. So this is a very effective drug. But note, it's not excreted in the sweat. And that's in contradistinction to griseofulvin, which is excreted in the sweat. And this is of relevance when it comes to the treatment of certain types of fungal infections of the scalp in kids, but we'll come to that shortly. Fluconazole is a drug that is mainly used for yeast infections, and it can be given just once weekly. It'll accumulate in the stratum corneum through sweat and direct diffusion. It's mainly used for people with yeast infections. Most of these drugs work by interfering with the formation of the fungal cellular membrane, and this leads to disruption of it. The main practical things I want to get to with these drugs are reflected in these slides. So let's just bring this particular slide up here and have a look at it. Namely, what are the rare side effects associated, severe side effects associated with these three drugs? Well, with terbinafine, the severe side effects are these: angioedema, sometimes toxic epidermal necrolysis, some psoriasiform eruptions or exacerbation of psoriasis. So, there's a lot of patients out there with psoriasis. This one, acute generalized exanthematous pustulosis. It's one of the causes of a generalized pustular eruption. It can occasionally exacerbate cutaneous or systemic lupus, so watch out for that. Depression is a bit of a problem with terbinafine. Loss of taste and smell abnormalities, that's reasonably common. And agranulocytosis, or sometimes just a neutropenia or thrombocytopenia, can occur, usually at about 4 to 6 weeks into taking the drug. So a lot of people recommend just doing a blood test at around that time just to see if there's any signs of this. In general, this drug is really very safe to take. And we use it mainly for severe onychomycosis, fungal infections of nails. There it's used in a dose of 250 milligrams daily for generally about 12 weeks to deal with fungal infection of toenails, and it's effective in about 90% of cases if it's used in that way. Note it's fungicidal, so the fungus is dead, but it takes a while for the nail to grow out, for the dead nail to be expelled. Worthwhile just checking liver function tests with this, but it's not as big an issue as with itraconazole or, say, ketoconazole if you're using it for any length of time. So terbinafine is a good drug and a safe drug. Itraconazole, though, it It has a variety of drug interactions that we'll come to. But note it can also cause some of the same skin side effects that we associated with terbinafine, but again, not terribly common. Again, a leukocytoclastic vasculitis, erythema multiforme, occasional alopecia, photosensitivity rash, and some of these other little problems, occasional cardiac failure, hepatotoxicity, and a serum sickness-like reaction. A serum sickness-like reaction is going to give you an arthritis and, say, a vasculitis-like picture. As I say, the big issue with itraconazole is its drug interactions, and we'll come to these, but you can get some of these unusual severe skin side effects. With fluconazole, mainly anaphylaxis, bit of cholestasis, this problem here, QT prolongation and torsade de pont, they end up getting some ectopic ventricular beats, and that can sometimes lead to ventricular tachycardia. Rarely with fluconazole you can get severe liver disease. You're much more likely with ketoconazole to get severe liver disease, but again, only for prolonged courses of therapy. If you're using ketoconazole just to treat, say, pityriasis versicolor, where you're using it 200 milligrams daily for 10 days, and then 200 milligrams weekly for, say, 10 weeks, you're not going to run into any trouble, and one rarely, if ever, does blood tests in those circumstances. Okay, we've kept mentioning drug interactions. What about drug interactions? Let's have a look at some of them. With terbinafine, watch it with the tricyclic antidepressants, doxepin and amitriptyline. It can certainly make the side effects of these medications much worse. The issue there is that it can cause some of these cardiovascular problems, these QT elongations, as can occur with terbinafine and these particular drugs as well. More common though with the with ketoconazole, these ones here. Watch these. Don't use them with the antihistamines, terfenadine, or terfenadine and stimazole, I should say. Watch it with those, because again you can get these severe cardiac rhythm problems. And with itraconazole, quinidine for rhythm disorders, pimozide, this was a tricyclic antidepressant that was used in dermatitis artifacta. It was used in patients who have delusions of parasitosis. It's not available in Australia nowadays, but you always have to watch it with cardiac side effects on its own anyway, and it's exacerbated with itraconazole. Warfarin's a big problem with itraconazole. The effect is increased, so you've got to watch for an increase in the INR when you add in itraconazole to patients with warfarin. Can interact with some of the calcium channel blockers and some of the statins, and it will also increase the toxicity of cyclosporin and the oral hypoglycemics in the sense that it'll make them more effective if you're using itraconazole with patients who are on these. And it really interacts with a lot of drugs. Just be aware of that. And it's useful to have some form of computerized drug interaction system to put a patient's drugs in via itraconazole and just see what the likelihood is going to be. Again, there are interactions that are clinically very significant because they're potentially serious, and those that are relatively minor. So it's a drug that if you're going to introduce it to a patient, an elderly patient who's on a variety of other drugs, then double check, or else you'll be getting a little phone call from a pharmacist. Now, lastly, let's look at some treatment situations in relation to these drugs. We mentioned before about whether the drug was excreted in the sweat or not. And terbinafine isn't excreted in the sweat, whereas griseofulvin is. And for a fungal infection such as Mycosporum canis that's causing tinea capitis, this tends to be an ectothrix infection. In other words, it's affecting the outside of the keratin of the hair shaft. And if you give them terbinafine, the drug doesn't penetrate adequately through the keratin to the cells on the outside. And a drug such as griseofulvin, which is excreted in the sweat, is more likely to be effective in Mycosporum canis. Whereas in Trichophyton tonsurans, which is an endothrix infection where the fungal spore is seen in the inside of the air shaft, then terbinafine is the better drug for that. So in children, griseofulvin still for Mycosporum canis, terbinafine for Trichophyton tonsurans. In most in most just surface skin infections, as in tinea cruris, corporus, or pedis, then topical therapy is usually adequate for the vast majority, unless it's very extensive tinea corporis. If it is very extensive, then taking an oral antifungal such as griseofulvin or terbinafine is the better way of treating it. And probably terbinafine is the drug of choice. And again, if you've got an immunosuppressed patient, in dealing with your fungal infection, it's part of your body's immune reaction plus the effect of any drug. And if you're immunosuppressed, you find topical therapies just aren't enough. You need to have oral therapies to try and deal with it. The other thing is griseofulvin and terbinafine are no use in tinea versicolor. It's a yeast infection, and these will not work. Itraconazole, ketoconazole, fluconazole, they will work. Generally, as I've said, we use ketoconazole 200 milligrams daily for 10 days, then 200 milligrams weekly for 10 weeks. Itraconazole, it can be quite useful for prophylaxis, and they were suggesting 400 milligrams monthly. Usually I think it comes in 100 milligram capsules, itraconazole. So just taking 4 of them once a month can be quite effective for tinea versicolor prophylaxis, because remember, the tinea, the yeast organism that's involved here, it's part of the normal body flora, so it tends to build up again. So something like this is needed. Of course, you can use topical Peveril foaming solution or selenium sulfide in Selsun shampoo. Can leave that on overnight, wash it off the next day, and that can be quite effective in preventing the build-up as well if used once a month. And then if you have deep fungal infections such as sporotrichosis, chromomycosis, chromoblastomycosis, and all the other funny ones that you can get, then itraconazole is generally the best drug for these. But again, it may need a dose of 200 to 400 milligrams, and this has to be kept up often for 2 to 3 months to completely eliminate some of the deep fungal infections. There's a lot in the pharmacology of these particular drugs. It's well worth getting the books out and having a little look and reminding yourself. Just remember the drug interactions with itraconazole, watch with the azoles and some of the antihistamines and the risk of cardiac arrhythmias associated with those. And remember griseofulvin for Mycosporum canis, tinea capitis, and terbinafine for the endothrix T. tonsurans. And that's related really to how they're in fact excreted. Thank you very much.